Afternoon, it's Matthew Holt. It is January the 27th. We're nearly out of January already in 2022. This is the THCB gang. Fun group today. I've got a couple of regulars and a couple of special guests. Looking forward to this one. Mike Magee and Kim Bellard, my regulars, are on with me. And we have two guests who have both done interesting different things lately. One of them is a return guest, Shantanu Nundy, who is the medical director of Accolade. Also has just wrote a book last year called Care After COVID, which we had on to discuss, and just has put out a new piece in Jama, which is pretty interesting. We'll talk about that. And Janae Sharpe from the Sharpe Index, who has been banging the drum about physician burnout, physician suicide, and has some awards to talk about. So looking forward to this. So hope everyone is doing fine and well. I see Janae has got her pink Christmas tree / monster behind. So let me start off just the same way I always start. We're just asking people what they've been looking at the last couple of weeks since they've been on. I think they've even been on this year yet, Kim. So what have you been looking at?
Well, just today, I guess it was yesterday, San Jose announced they've got a proposed ordinance that would make gun owners buy liability insurance for their guns, as well as pay a fee towards any costs that might result from the use of those guns. So I wrote about this a couple of years ago because they've been talking about it for 3 years. And I just think it's a great to make insurance the weapon against bad gun ownership. So hopefully they're successful, and people that own assault rifles and so on have to pay really high insurance fees, like they had a very expensive dangerous sports car or something. So I'll be curious to see if they manage to get this through the courts and get it enacted, and if it takes off. But I think it's a very novel and innovative approach to a real problem.
Yeah, I interviewed the current surgeon and former and current Surgeon General, who wrote about this a lot. And I was told when I interviewed him, most people do not mention guns. So, I hope that this public health guns issue comes back. We'll see. Mike, what have you been looking at?
Matt, two things. Before I got distracted by the Justice Breyer announcement, I've been chatting for the last week or so with a group of my historian friends who are saying that as this COVID pandemic wanes and we may be coming to some general conclusion of it, what we're beginning to see is social scientists of all types begin to reflect on what is the larger historic meaning of this COVID pandemic, and whether it is very much reminiscent of other pandemics we've had. What have we learned? Is humankind any more prepared the next time around? So they're beginning to look and reflect and write on the historic context of this, even though it's not scientifically completely shut down yet.
Hopefully they'll be reading Shantanu's book to find out what we're supposed to do. It was pretty good. All right, so Janae, I'm going to give you. I'm not going to introduce you guys yet, but just want to quickly find out a little bit more about what you've been looking at the last couple of weeks, what you've noticed.
What I've noticed in general, that when it snows in North Carolina, everything shuts down. Here and they're like
from Utah,
Virginia too.
School might be canceled tomorrow because we might get snow. We also have been doing awards and giving out the awards. I realized everyone I've talked to has been like, this is such a highlight of our day. Like, it's been awful this week. So I've kind of noticed a lot of people feeling super down, like super overwhelmed, and everyone on my team got COVID. So it's been, that's what I've noticed. Like I was kind of overwhelmed, and then it seems like I talked to people and they were too. And it's just totally weird year so far.
It certainly has been. I've noticed a lot of discussion, some of the Slack groups I'm in about certainly about mental health and some of the companies doing what are mental health. Shantanu, what's your quick take on the last week or so?
Yeah, well, actually, I've been buried in reading a lot of fiction the last couple of weeks. So I've been reading a lot of old Robin Cook and old school Michael Crichton from when he was a med student and kind of wrote it under a pen name. And I think my big takeaway is, in fiction, especially fiction about healthcare, is actually more real than sometimes nonfiction in healthcare. Just like laying bare, kind of how much greed and corruption and stuff has really gotten a hold of our healthcare system here in the US, and how sometimes through fiction you can just tell like it is. So,
well, that may be the case. I mean, most fiction written about the last few years has been it's been more believable than reality.
I've also been obsessed with this quote. Sorry, it's just on my mind. I have to say it. There's somebody tweeted this thing. You know how it happens, and they quoted the CEO of a health insurance company, which I probably shouldn't be talking about. But the quote was, he said, "Oh, it's really interesting how the system is designed to separate the mind and the body," and everyone was like liking it and stuff. And I was like, yeah, wouldn't it be nice if, I don't know, like the CEO of like the largest health system in the world could, I don't know, do something about that? It's just like everybody wants to play the victim and nobody wants to step up and say, I actually can do something about this, and I'm going to do something about this. You know what I mean?
Just an innocent bystander. Absolutely.
Exactly. Hey man, I'm just picking up a paycheck here.
Well,
I don't really say what happens,
Fantastic. Well, so I mean, I've been noticing. I'm still can't get over what I noticed on last week, gang, which is the fact that I still think this is the single craziest thing I've heard about the last 5 years, and that's saying something, right? Which is
tell me.
The chief public health officer of Orange County, Florida, is put on leave for asking people to get back, asking his own staff to get vaccinated. And so I'm repeating myself last year. The other thing I saw this week, which is fascinating, was I'm on this health tech nerd Slack channel, which is very fascinating. And the chief medical officer of Cerebral, which has been growing incredibly fast as a mental health company.
I signed up for them.
Well, I'd be interested. We can chat about it later. I know I want to.
We can do that offline. Otherwise,
online, offline. We'll get there. But we
can try them all out. Like sign up for them and try them all out.
Well, they've been criticized a lot for but they've grown incredibly fast. I mean, hundreds of thousands of users on the platform, and they're doing a lot. They've done a lot of studies. We'll have to discuss good, bad, and different. But it's probably the fast. I mean, when everyone talks about how fast digital health grows, that's its competitors like Lyra and Ginger and Headspace and others, grown over time. But the fact that they've grown so fast and only were founded less than basically 24 months ago is remarkable. And I don't quite know what it says, good, bad, or indifferent about the future of health. But you can, found new companies to move very quickly, which is something we always said in digital health couldn't be done. So I'll hold off on that. We'll think about it a minute. But what I want to do is go. Both of you have got a number of key big issues, and I want to introduce to the people who haven't met you too much. So, Janae, I'm going to start with you. Tell us about the Sharpe Index. Tell us how, unfortunately, you got into the whole concept and business of this, and tell me what you're doing with the Sharpe Index.
The Sharpe Index is a nonprofit dedicated to improving physician mental health and reducing suicide. We started it a few years ago. My former husband died by suicide. He never finished his residency. He was got his MPH and then went on to do medical school. And we have 3 children. And I worked in health IT, and I don't know, somehow ended up starting this nonprofit to improve things for physicians. And this is in 2018. And this year we've done a ton of things. We started a fund for giving money directly to nurses and physicians, frontline healthcare workers, to pay for childcare. That's the Cat McDavitt Fund. And we also do awards every year. So we gave out awards. I was in a conference once and someone was like, if you want men to really care about women in tech, like give them an award, make it a contest. And I was like, I could get on board with that. Like, so we have awards every year, and we just gave them out, and it's been kind of cool seeing all the stuff people have been doing.
So tell us 2 things. One, what's the core work, of the index in terms of the nonprofit, in terms of the your mission around physician burnout, suicide, etc., suicide prevention, and etc. And tell me more about, and then after you talk about what are the awards? Who won?
We do a few things. Some of it is a direct action fund. Some of it is student loan forgiveness scholarships, and also we help improve health IT, whether that be with giant companies or hospital systems. And I don't know, we do a lot of stuff. Anything that would improve physician mental health, we help promote that and work with the press and improve the kind of perception and awareness of what it is. And you can see that too in the last 2 years. It's drastically different than when we started talking about how like healthcare is hard, taking care of everyone is hard. And at first people would just, say, oh, they're whiners. And I think this last few years, people have realized like, okay, it is hard and it's kind of a nightmare.
So I would say that, we heard a lot about burnout previously. The last 2 years, especially with, some of the violence and aggression towards medical professionals, nurses, doctors, especially from the sort of anti-vaxxer crowd in COVID, it's been, remarkable.
Yeah, people don't necessarily like to work with like in a hateful environment.
Sure. That's not much as much. Mike, I would ask you, you were a doctor, I've been a doctor for a very long time, and looked into this. Do you think this notion of sort of physician burnout is something that was new? Was it always there and just not discussed? Was the issue of physician mental health? I mean, is this something that has always been there? We've always beaten the living snot out of our healthcare professionals, and we only have started to talk about it, kind of like, Me Too and other issues? Or has it got worse?
Well, it is interesting. I grew up in a family of 12. My dad was a doctor. His office was attached to the house. So literally, I've been in the middle of medicine since I could crawl. Finished in surgery at UNC in Chapel Hill in 1978. And during that period of time, we had a very prominent suicide of a fellow not one of my residents, but a resident at Duke at the time. So the issue was front and center there. I went up to New England and practiced right on the Vermont, Massachusetts border in a very small town, 100-bed hospital in rural New England. It was an issue there. Got into management of hospitals, and whether it was that small rural hospital or Pennsylvania hospital in Philadelphia and everything in between, part of my role was always managing physician satisfaction as well as patient performance. And what I found was that it has been present forever. And I think in the beginning, when I first had to confront this and had to think about it, I focused on two things. One thing was it's a tough job because you're kind of expected by the moral code of this to be available to your patients, to be married to your patients 24 hours a day, whether you're on call or not. That certainly was front and center in rural settings. And as a result, the burden, just physical on you, the sleep deprivation, the constant kind of second guessing that goes on in your mind, did I make the right decision on this patient or that patient? That's ever present. And then when you add to that your existing humanity, your own mental health issues, it can become overburdening. So the fact that this was a very difficult job was something that I was always conscious of. The second side of it was, in reality, people are going to judge you. People have an expectation. Your license is tied to your performance. And so, as with the military, if you complain, if you go public, you're running at some risk in terms of your job. So we went to great lengths to try to create confidential avenues for doctors to come forward, nurses to come forward, and same thing for nurses, by the way, as for doctors, to come forward in a protected kind of legal setting and try within our own professional network to assist them. And I'd say we were relatively successful. Now, the only other thing I'd say about all of this long-winded answer is that I did work with a group of social scientists beginning in the late 90s, and we developed a empathy scale. We were trying to figure out, why do people who go into medicine and start with a certain amount of empathy, by the time they finish medical school, have drained that down by 50% or more? And then once they go to residency, it just keeps going down. It's down, down, down until they actually, finish. And we came upon two answers. Number one, the training period itself was brutal, and unnecessarily brutal, and that was part of the reason why we were destroying these doctors at an amazing rate. But the second thing was, we felt that we only got the selection process, that is, who we chose to become a doctor, right 2 out of 3 times. So we felt that, in retrospect, looking at psychological testing, that we had mischosen candidates 1 out of 3 times. And the major measure we were using for this was arrogance. We were measuring 30 different psychological traits in these individuals. And what we found is that if we chose a doctor who was scoring very high on arrogance, number one, we couldn't train it out of them. They had a lot of difficulty admitting that they didn't know something, and they had significant mental health burdens.
Yeah, so now you just channel them all into being orthopedic surgeons, no doubt. Okay. Harsh, but fair. Shantanu, one of the things that a lot of doctors are doing now is like they're going through the process and going, I can't deal with the practice of medicine, so I'm going to go off and find something else to do. And you're one of those people who've been balancing that, right, between your work in the clinic and also your work with a digital health navigator startup, whatever you want to call it. The other thing is that compared to when Mike's, I'm making this crass assumption, but I think it's true. Compared to when Mike went through the system, there were limits placed on how much residents could do. I know my father, when he was who's now sadly died now, was complaining about how these young doctors only working 100 hours a week. In my day, we worked out 400 hours a week or whatever. Do you think that these two things, right, the change in residency and the ability to go somewhere else, is helping or hurting, or is it making doctors who are in the system now look at people like you with sort of jealous eyes, going, "Oh, I could go off and be a medical director somewhere"? How do you think that the change in the profession is impacting this sort of burnout and risk of suicide?
Yeah, wow, that is a good question. I'm certainly not an expert in this. I think I'd love to hear more from Janae. I think like everything, it's like just because I practice medicine doesn't make me an expert in burnout. But I think the one thing I'll observe is sort of very similar to, I think, just general population, where we all just have so much more awareness of what everyone else is doing, right? And I think, that's true for physicians. I mean, yes, there's a lot more things that physicians can do, but just the awareness of all those different alternative paths are much more present. I mean, certainly when I was in training, and it wasn't maybe as long ago as Mike, like even then, the only option was researcher or practicing physician. And I definitely am seeing way more young people early in training or even in college reach out to me saying, "Hey, how do I get to do what you're doing?" And it's like, what? Like, I went to medical school just to take care of patients, and later I figured out this other stuff. And so it's definitely happening earlier. Now, whether it's contributing to burnout or not, I think I don't want to speculate, but it's certainly the awareness is there. And I think recognizing that, when you see, I think it's the same thing maybe affecting teenagers. They're seeing what their friends are doing on a Friday night and what they're doing, I think on some level, and it always seems shinier on the other side. And maybe in some way that is contributing.
I think also it's important to note that some of those work hour requirements don't necessarily include things like increased documentation and increased work burden outside of the hospital hours.
Absolutely.
They're
Absolutely.
two
Also,
macro-
people lie. I'm sorry. Like people lie about their work hours. There's a
For sure.
reason they don't have you clock in and out in residency. And it's not so they can comply with the rules.
Kim.
There are two sort of macro trends that I wonder have a big impact on burnout. One is the whole patient empowerment movement of the last 25 years. So patients are less likely to, doctors are not God. They have a little more information, but even worse, now patients are being, belligerent with their doctors saying, not only are you not God, you're wrong and I'm right, and I'm not going to take your advice. So it's got to be very stressful. The other one is the corporatization of medicine. More of them are, owned by somebody, and they have less control over their life and more dictate to the corporate masters who they think are impersonal. So it's between those two things, doctors are facing an environment that they were not used to in the old days.
And
Yeah,
nobody
I totally agree. Oh, sorry. I totally agree.
Nobody wants to follow the man.
Yeah, like exactly. Because I think if you look at a controlled experiment, right? Like look at physicians today. So trained in the current work hours, dealing with social media, whatever, those that switch from the corporate practice of medicine to a concierge direct primary care or concierge practice, you see the change. I mean, I've literally seen like people physically change, like when they went from A to B, right? And similarly, I mean, I'll say like the physicians that work for us, I mean, our NPS for our physicians is in the 70s. Like you can see that how much better off they are in an environment that just sets them up. So that gives me hope, right? That it's like, it's the system stupid. And that it's not that my generation of doctors are weaker or, that, we got spoiled in residency or whatever. It's because if you change,
I mean, maybe you are, but that doesn't matter.
Yeah, maybe I'm weaker. Yeah, that's true. But as soon as you change their circumstance, like you can see people thrive, and like that gives me hope.
I hope the next generation can be weaker. Like I know that people talk about women in tech, and I'll go to things and they're like, "How do you get away with that?" I'm like, you know what? I hope someday when my daughter's like in tech, she can be like, "Of course I get away with this." Anyway, sorry, Kim.
I've had several Twitter battles with direct primary care doctors, and if you even hint that it's a good idea that someone looks at what they're doing in their practice, quality is important, and review of things, they get belligerent. Nobody should be questioning what I do. So some of those people that are in direct primary care are in it for a reason that is not necessarily the reason that we should be looking for. So I agree that there's some value in it, but there's a danger too that there is some sort of oversight that is important to have, even for physicians.
I would say that whether it's whatever the solution is, right, whether it's some kind of managed telemedicine / concierge advocacy program, I don't know what you want to call Accolade, Shantanu, or whether it's going to like a subscription-based direct primary care. I think a lot of the pressure of seeing people, seeing a lot of patients and not having that not having as much continuity care and sort of being forced through the treadmill of seeing dozens and dozens of patients in a day rather than an hour visit or half hour visit. A lot of that has got to do with the structure of the payment system. And then actually, I went to see my chiropractor the other day, who happens to have an office right across from One Medical, which is my primary care doc. I don't know how One Medical does it, but we were discussing this. When I got my bill from him and my bill from One Medical, I wrote about earlier this year. It turns out the chiropractor, for good or ill, has got to see 10 times the number of patients that the primary care doc at One Medical has got to see to get the same amount of money paid for, right, in there, in terms of received from my insurance company. And I'm going, that meant the primary care doc at One Medical, good, bad, or indifferent, had a lot of time to talk with me about a bunch of stuff, some of which even concerned my health. Obviously, mostly we talked about health tech and skiing and whatever else. But I'm wondering, the question, and this is the question I've always felt, especially around primary care. I don't know how much of this, Janae, is between hospital medicine, primary care, and specialty care. But you could argue that we could build, if we just took enough doctors or NPs or whatever, converted them from specialty care to primary care. I know that's a bit of a fantasy, but we could do that. And you gave them all essentially 500 patients each and gave them a whack of money associated with that. We could build a primary care system where every doctor had 500 patients. They could spend an hour with each patient. They could spend the kind of continuity. We could get to that system. Obviously, we have to take a massive reduction out of what we spend in hospital and specialty care in order to do that. But the math kind of does work out that it, and we have to change all the stuff, that it's possible to do that. So I think if we were brave enough to change the system, we could make it better for patients and doctors on a primary care front. So, well, I don't think we're going to get to do that, but if you run the numbers, maybe we could. But Janae, I want to ask you, do you see any variation in the kind of people coming in the work you're doing and the doctors and nurses coming to you about location of care and system of care they're in, or is it across the board?
Okay. In our surveys, we did have more doctors that are burned out that are working in the VA, but that's not like published. I will say this, if you don't work with super poor populations and super underserved, sometimes it's easier. So I don't feel like that's like life-changing. Actually, one of the award winners I thought was interesting because they tied executive pay to the outcomes for underserved populations or for, homeless people. And that was amazing. So yeah, the main significant difference we saw was that VA physicians, this is self-reported, had higher rates of burnout. And other than that, it was like pretty crappy for a lot of people, I'd say. Also that men were, in our survey results, more likely to like want to be contacted. So that's all.
Interesting. Are there any other parts from your findings or any other things that we're not talking about enough in terms of physician burnout? Is it something that, or is there an obvious?
I do think we should talk.
Solution?
I do think healthcare in general should talk more about like the reimbursement burnout issues. Like think about how much more you have to do if you want to be able to take Medicaid patients and how much less you get reimbursed. Like what are we doing here? like, so you're going to be less happy because you have to do more work and you're going to get paid less. So anyway, that's not necessarily the most fun.
And are there any solutions that that seem to be percolating up? I mean, obviously, like I said, they make everyone a concierge doc and give them 500 patients and attach a whole bunch of money to it, but there are solutions that within the system you think are where you've seen some good results but haven't been spread, or that people got good ideas, or is this more about giving counseling?
I mean, I think Medicaid people care a lot, so they do have programs like the innovation programs and funding are pretty cool. I don't know if they're always sustainable.
Do your surveys talk much about doctors versus nurses and the rates of burnout between the two?
So historically, we have not surveyed nurses until recently. And part of that was like when we started the Mom Fund, the founding donor was like, we have to be able to give money to all the frontline healthcare workers, including nurses. And which has been really good. So we haven't ever done like an official study with nurses and physicians, but we will.
Yeah,
things are different. Like nurses are quitting a lot, which is fine.
Well, there's some weird stuff going on, right? Because also nurses are quitting, but also a lot of nurses. If you look at the funding, there have been 4 or 5 essential staffing agencies. They're dressed up in trendier terms now, but which have been funded in order to help nurses, and there are now a lot of nurses who are travel nurses in quotes, but are now going 45 minutes away from home as opposed to 20 minutes away from home and getting paid a lot more. And staffing is an incredible crisis across the board in America generally, but in nursing in particular. So we're seeing a lot of that. And before we leave this topic, Janae, what would be your kind of one magic wand? What's the one thing you think that as a society or as a system we could or should do to help with this overall problem?
That's a good question. I normally ask other people that question. People don't ask me.
If you're going to come on here having started an organization to deal with this issue,
this is a great
one. One quest.
I think each individual person needs to not assume that anyone else is going to take care of it. Whether that be like help your friend who might be struggling and show signs, or start an organization or donate, like assume that you have the power to help and you should do something. Like, don't be like, reach out if you need something, just call your friends.
Yeah, I think team approaches have proven to be useful, both from the standpoint of addressing equity issues, but also from the standpoint of mental health. And,
Oh, yeah.
and you know, it makes sense when you think about it, because, you know, what really disrupts the inner sanctum of a doctor or nurse? Chaos. They don't like chaos, with good reason. They don't like poor outcomes. They don't tend to handle silence very well. So if they're stewing about something and it's just building inside and they don't have an outlet to express it to somebody else, that's not good. And they don't like, I think, to be isolated. And so team approaches to care offer potential help in all of those areas, besides the fact it's more realistic, you know? So I think, at least looking back over what now, 5, 6, 7 decades, when I saw doctors and nurses get in trouble, it usually was because they felt that in some way or another, they were either personally failing or they were not delivering what they wanted to deliver for their patients. They felt like somehow they had not really lived up to their own high expectations. And so, you know, I think, hey, it's a tough job. Maybe the problem is the system itself. And maybe we're asking people to do the wrong things, you know? I mean, what really makes a doctor happy is if they successfully are able to demonstrate compassion, understanding, and partnership, and somebody physically or verbally acknowledges that to them, pats them on the back. In the old days, in the 50s, when it got close to Christmas, our dining room table was filled with baked goods. The patients my father took care of were all poor, but they gave him baked goods at Christmas time, you know, and he was happy, you know, because to him, that was saying, hey, you know, you helped my family. It was more personal. So I think the farther we get away from personal interactions, the worse it's going to be for doctors and nurses. They need to feel the flesh. They need to have somebody pat them on the back, just like they're patting the patients on the back. And it's the job of people who design these healthcare systems to provide those opportunities. If we're taking those opportunities away because they're collecting the data for the sources that go to the PBMs, that's not a good trade-off. Even if they're paid a bunch of money, it's not a good trade-off. You got to give them a chance to physically be doctors, be nurses, and that doesn't mean that none of them are going to get in trouble because we're all human, but I think it's less likely that they're going to spin out of control if the patients have their back.
So the answer is we need to buy more cookies. Excellent. All right, let's shift gears a little bit here. Shantanu, you have just recently this week published an article in Jama. We have the triple aim, right, which is cost, quality, and access, which has been fixed for a long time now, so we need to worry about that.
Absolutely.
I'm kidding. Then there was the quadruple aim, which is adding in, you know, the satisfaction and well-being of the staff who work in the healthcare system, which we probably just spent an hour talking about. And now you're adding one more because we fixed those 4 so well. So tell us about your article, which you wrote with Lisa Cooper and Kedar Mate. I hope I pronounced Kedar's name right. Who I've just discovered Don Berwick is no longer the head of IHI. I didn't realize that. I just assumed he was there forever. but Kedar is the head of that. But tell us a bit about this concept of advancing health equity as part of a new quintuple aim.
Yeah, absolutely. So, I mean, you know, there's a famous quote attributed to John F. Kennedy in some speech. Although, of course, when you Google it, you know, he's like, well, did he really come up with it? But basically, you know, he was talking about the economy and talking about approaches to improving the economy. And he said something like, you know, a rising tide lifts all boats, right? And the notion, right, is that if we can invest in the general economy, the economy does great. and the tide comes up and all the boats come up, right? And I think that's been a prevailing notion, right, in healthcare improvement and healthcare innovation is, look, let's just make it better and it'll be better for everybody. And I think coming out of, frankly, the last, centuries of medicine, but really accentuated by the pandemic, I think many people are waking up to the fact of like, wait, is that really true? Do all the boats really come up? And it's this idea that, amazingly, for all the equity talk we do, like health equity is not a goal of healthcare, right? If you go to our triple aim and our quadruple aim, it's not explicitly in there, it's implicitly in there. If Don was here, I think he'd say, absolutely, it was in the intent. When we talk about care and access and outcomes, we're talking about that. And the IOM report talked about specifically marginalized populations. But I think if you get to the front lines of where that quality improvement, where that innovation is happening, it's really the assumed result. It's not the explicit goal. And so our whole idea behind this paper was saying, let's make health equity an explicit goal of healthcare improvement and innovation. And that's what the quintuple aim is.
Yeah, it's a really nice, it's a fine and nicely done short paper by Jama standards and non-technical if we want to go take a look at it. But I think one of the things that's fascinating me is that you found out, right, 22 years ago now, right, in the IOM report about crossing the chasm, this was called out as one of their 6 or 8 things. And yet, when it came to the rubber meeting the road and what actually happened in terms of care for all the different reports you've had, about maternal childbirth amongst Black women, obviously all the issues around the COVID, during COVID about, public health and prevention amongst poorer and African-American Hispanic populations. Going down the list, there's a whole bunch of stuff where we don't seem to have made a whole lot of progress from the stuff that I was taught about doing health service research 30 years ago. So other than just calling it out, what should we actually do?
Absolutely. So the best part of the paper is actually the table that's what I really wanted to write the paper about. And of course they made it a supplement. So I think it's really 2 things, right? I think the first is a lot of the improvement or innovation we're doing with an unintentionally is making health equity worse. And so we need to design or redesign those interventions thinking about equity. So let me give you an example, right? Every clinic everywhere in America, I guarantee you, every couple of years says something like, we're going to improve colon cancer screening. This is like a thing. We all do that. And the way we do that is we say, okay, let's train the medical assistants. Let's lecture the doctors. Let's add a little button to the EHR, right? That's what we do. We do it every couple of years and it's fine. But here's the problem. When you do that, by definition, the only people being impacted are, guess what? Patients that are coming to clinic, right? Because that's who you're serving. You're serving at the check-in, you're saying, do you do this? And you have the button and you have the measurement. And so what we're trying to say is you have to step back because that actually increases inequity because the people that are in clinic by definition are sort of more privileged and have more access than those that don't. And so if you want to take a population and a health equity approach, you got to say, well, what else could we be doing? And there's things you can do, right? Like look at what we learned during COVID with the vaccine distribution. Start proactively calling people, partner with the church and do a colon cancer screening event at the church next door, just like we distributed the vaccine. So the first thing, Matt, is we got to take the investment that we think about it explicitly at the outset and be able to do that. And then the second one is there's a whole bunch of innovations and interventions that we're not even thinking about because we're not thinking about health equity explicitly as a goal. So like a really good example is like most clinics, particularly those that take care of the underserved, we don't attempt to help people get better jobs or better education, right? Like we do a lot of connecting to so we have social workers that connect them to a bunch of different things, but we don't think about a job support as an example, right? Or we don't think about in our employers and our businesses access to healthy food. So once you take the health equity lens, you start suddenly opens up a whole bunch of interventions that will primarily, improve health equity. So those are the 2 things really on the ground we need to do.
So do you think that I get this of the health policy guide lens and then putting the lens down into education and structure. There's also been a lot of activity in the sort of venture capital backed world around the topic of Medicaid, right? You've got people like Cityblock who raise hundreds of millions of dollars, Unite Us who are trying to bring in sort of community services and get people from the healthcare system into the right environment. Does that stuff, I mean, and I've talked to, I actually had an entire panel at my conference last year with the leaders of a bunch of these organizations. Mm-hmm. And they all basically said, yeah, the government should have fixed this 30 years ago, but if they never, or 50 years ago, but if they never did, the next best thing is to get some venture capital money and see if we can figure out and make some money out of it, essentially, because that will help us, literally one of them, I think it was Dan from United said I was working on single payer stuff, but instead I went off to become a venture, to this venture capital backed CEO thing because it was the only way I could get, make a difference. Do you think when any of that stuff is moving the needle on equity, or does that require, is that sort of just playing around the edges?
So my answer to that is, look, if you think about health equity and you sort of zoom out, we know, it sometimes makes me laugh. We say social determinants or structural determinants of health, and then we immediately start talking about individual patients, right? The whole concept behind structural determinants is you have to fix the structures, right? Like the housing discrimination, the job, issues, the lack of schools. And I think ultimately it's those things that are going to move the biggest needle. That being said, on an individual patient basis, there are still stuff that we can do, right? Is that ultimately in itself going to solve the problem? I don't think so. So I think first you have to acknowledge that that's a fact. But within the individual patient stuff, yeah, I think some of those solutions, I think definitely have value. I think what we've learned in our work at Accolade is the most important thing is to identify what someone's barriers are, and then to incorporate that into the plan that you have, right? One of the things I cover my pet peeves is that so much of the industry is talking about, oh, SDOH, it's like this cool thing. And you're like, well, okay, well that data, if someone's food insecure, someone, has transportation issues, so what? The question is, what are you actually doing with that information to address that barrier? And that's what we found, that when you do that, right, that you create a better experience for people and you ultimately get to better outcomes. And I think that's the part that I don't hear those companies talking enough about, is they're like, well, we have diverse staff and we're serving the underserved population. Great. And we have data. Fantastic. But what are you actually doing then on an individual basis to close those barriers and improve health? That's the thing that I think remains to be seen.
Yeah, I think Sachin Jain, who's now at SCAN, has written a lot about this, and he said one of the things is, right, does your organization change how it's going to reward people based on who you're hiring, what you're doing?
He's the one who won the equity award, by the way.
Sorry,
he won the equity. Yeah, he's the one who they tied executive pay to outcomes.
Right. That was so Sachin's always win. He should win the I posted the most on LinkedIn as a big CEO award as well, if there is such a thing. I'm not sure actually it doesn't work other than writes on LinkedIn, but
I don't know if he has, though. I feel like some of those other guys are pretty prolific.
Good. Anyway, Kim, I want to bring you in because you spent a lot of time looking at the impact of people who spend a lot of money in the system, notably health plans and others. Do you think that we are anywhere? I mean, a lot of people talked about this, and people, especially when Black Lives Matter rioting was, the protests were going on, and there was real focus on this. So people were taking out full-page adverts in papers talking about this stuff. But where do you think we are in terms of actually having a real change in the way that the people who control the purse strings, like the guy that Shantanu mentioned, who was the head of the health plan, saying maybe we could change the system? Where do you think we are on this?
No, I think we're tinkering around the edges of the pretty stuff, but not getting to the core problems. When Shantanu was talking before, I was thinking there are two things that really distress me. One is that it's not clear to me that even in systems that have universal health care, that health equities are any less. I mean, every healthcare system has problems like this. Right. And secondly, until you solve economic inequities, you're not going to touch health inequities. So you got to be talking about stuff like, universal basic income, baby bonds, all sorts of structural stuff that are core societal things that, the healthcare stuff looks easy by comparison. So, till you get your hands around those, there are going to be these inequities that should shame us.
I mean, which gets us to something which, you don't want to talk about much. You don't hear much from the the crowd in who I was on a Health Tech for Medicaid conference that was done this year by that group, Anamika Arthur and her group, which was great, right? Everyone's talking about structural racism and the terrible things going on. And I'm going, okay, let's look around the corner and what's going on in DC. We have at least one party that seems to be very interested in perpetuating this this level of structural racism. They're probably going to win the House back next year. They may, we don't seem to have got very far in moving things along. We have a Supreme Court which has been very happy to roll back the civil rights protections and others that we've seen over the last 50 years. Is this conversation?
Can I just link conversation? Can I just link these two conversations for a minute? Because I think, so first of all, Kim, I completely agree. And I said the same thing. I think these upstream issues, the core inequities, structural inequities, that's really what we need to invest in as a country. But I think left often in the middle are the physicians and the nurses who are sitting there saying, what can I do for this person? And I'm feeling, right, like that's the moral injury that they feel, is sitting there saying, what can I do? And so I always think about one of my favorite studies of all time. One of our medical advisors, this gentleman, Saul Wiener, who's a physician up in Chicago. He did this really amazing study where he sent a bunch of patient actors to a bunch of different doctors' offices all over Chicago with tape recorders. This is all above board with an IRB. And they each played an actor, a patient actor. And that patient actor was this character of this, I think, Aaron James or something like that. But it's like some middle-aged guy who was having trouble breathing and had asthma, right? And he went to all these different doctors' offices and basically gave a very clear script. Hey, I'm having difficulty breathing. I have asthma, But the key to every one of these visits, at one point of the visits, he drops a hint. And the hint is, he goes, oh boy, things have been tough since I lost my job, right? And that's the moment that the doctor was supposed to be, oh, I'm, sorry to hear you lost your job. Like what? And it was fascinating because the majority of doctors, right, they heard that. And it's funny, one of the transcripts, all recorded, one of the transcripts, the guy goes, oh, I'm so sorry to hear that. Do you have any allergies? Right? Like, and I was, as a physician, when I see that, I thought like, wow, that could have been me, right? Like it's, it happens. And what happened is a lot of them left. Terrible. Right. And a lot of them left, a lot of the patients, actors left the visit with an order for an expensive lung test and a more expensive, like the next level inhaler, right? Like, which is funny because that's actually evidence-based medicine. If someone is not responding, you kind of keep titrating up the curve, right? But the few patients, the few doctors that actually said, oh, I'm sorry to hear you lost your job. How's that affecting your health? Then immediately the story comes out, right? That like, hey, well, actually, because I lost my job, I'm not taking my inhaler. And that's probably why my asthma is worse. And they left with like a low cost, inhaler. And presumably that would have reduced the thing, right? And so that's the thing that we focus on, because I think physicians, like so much of us have this heightened social consciousness and we want to do good. But at the same time, we're overwhelmed with, okay, other than voting for the next guy or gal, like, what am I doing? And I think to me, that's really actionable. And I think part of what we have to do is, part of it's training for doctors and things like that. But part of it is just giving them more tools in their toolkit to be able to actually address those barriers. Like some of the stuff that NHS is doing, like social prescribing and stuff. There's a lot of stuff that can make them feel like, wow, I heard this thing and now I can actually do something towards that thing.
I think also to that, like under that same vein, there are some programs that exist that patients never hear about. We were talking to 100%. A payer that works in the Medicaid space, and they're talking about like, how do we educate patients to let them know these things exist? Like maybe there are programs to help you get to and from your appointments. Like there are partnerships with places like Uber. People don't know about them. Like physicians don't know what exists to help people, or they don't know about the social programs in the area. So I feel like that's a giant gap. There are actually tons of programs that are happening, that are being developed, like a loyalty program or rewards, but there's a gap where the physicians don't know enough. So patients aren't being able to take advantage of it.
One of my most heartbreaking.
This is like a sign that I had like the best physicians and like best pediatrician in the world.
No, I mean, one of my most heartbreaking stories during the pandemic was this patient who I'd been taking care of for a while. And she comes into my clinic and she goes, hey, Dr. Nundy, I really need your help. And I'm like, sure, of course. What can I do for you? And she goes, I need you to write me a letter. And I'm like, okay, let's do it. Let's write you a letter. And I said, why? And she goes, well, because I'm homeless And if you write me a letter that says that because of my diabetes in the pandemic, like I can get into this hotel, program, I can get into a hotel because I'm exposed to all these different, and I just was like completely flabbergasted. I mean, even now I'm still flabbergasted. Like I had no idea that this woman I was taking care of was homeless. That's like number one. Number two is I've heard about this stuff on NPR. I didn't know my own county had a homeless hotel program for high risk people. Right. And then number three is even when I sent the patient, and I did the little form, I was like, did this work? Did this not work? Did I get any information back that they actually enrolled? And all of those problems are problems that I think on some level are addressable. Like her address in our EHR is actually a homeless shelter, but I didn't know that. I just saw the address. But why can't the system query a public database and tell me that she's homeless? Why don't I have, then pulls up that there's a program in our area. And then why isn't there some sort of closed loop process back, right? Like those are the kinds of things we can do if we build the system with intent.
I think what you're both sort of voting for, though, is team approaches. You're basically saying that there is no one person who can do it all, and you need cues sometimes. I remember back when I was very young and in this rural practice, my nurse in the office was Jane Fields. And one time she comes over to me and she's angry at me and she says, "You have to have Mrs. Jones back in immediately." I said, "Why? What did I do?" And she said, "She feels that you rushed her. You rushed her out of the office. And you get back in there now and make that right." Now, did that offend me? No. That was Jane's job. She was protecting my back by protecting the patient. And so I followed her orders and that patient left satisfied. And I felt better about myself because I hadn't screwed up, So I think in so many of these things, if it's structured so that a team is covering each other's back and servicing the patient at the end of the day, that's how you make the linkages with communities. That's how you kind of cover your own weaknesses as a human being, But we're not structured particularly that way, even though you see team approaches in some of these big corporate care centers now. The truth of the matter is when you look at them, the individuals on the team don't seem to be talking to each other. They're basically all communicating with the computer. So because they're all entering their data on the same EMR, they think they're actually talking to each other. They think they're actually covering each other's backs, but they're not really. There's no flesh in the game. So I think maybe one of the things that health technologists and innovators could think about is how do you get flesh back in the game? How do you come up with some designs that force human interaction between team members and a patient?
Yeah, I think so. That's a great point. I would point out that somebody got funded with $40 million, a company called Atlas Health, well, just this past week. Jess and I reported on Health Tech Deals. It's basically a database of all the ways that charitable organizations or programs can pay for things that uninsured people can't afford, or maybe underinsured people can't afford. And I was going, this sounds great, but on the other hand, this is mostly aimed to help. They're going to go sell this to hospitals and physician practices in order to make sure that they get paid money, which otherwise they wouldn't get because they can't collect it from the people. So there's always to be the odd line between, if we're going to talk about these different solutions, let's hope they are there for the benefits of patients and the clinicians, not just for the corporate side of the world, because there's a lot of money already funding into this system. Anyway, I do have to ask you, Shantanu, one last question, right? So you're still in the split of the world because you work at an FQHC, I believe, and you also run a medical director for a company which, by and large, manages the care for health, not healthy, but for employed people who are decently well off, right? How do we get something like an Accolade, the sort of, and we have Navigator, not Navigator, whatever Glenn Tillman wants to call that segment. How do we get something like that where the kind of help that someone at Comcast who calls and gets an Accolade employee to really care for them gets to everybody? How do we spread this?
Yeah, no, I mean, I absolutely think everyone needs that, right? I mean, I just go back to the basic idea that my cell phone over the past 2 years is like every day ringing and messaging off the hook with people trying to figure out where to get a vaccine and what to do with their surgery. And like, we all need someone to help guide us through the healthcare system. And I think historically that was a primary care physician, maybe Mike, your dad. But, today it doesn't necessarily have to be. And you're right. I think the starting point, I mean, I just got to say is we have to move to universal healthcare on some level, like however we fund that, that's a must. But then I think very quickly after that, people have to realize that having a doctor or having a clinic is not enough. I mean, maybe this gets Mike to your team point is that, that's not enough for us to really live our healthiest lives. And that, given how complex the healthcare system is, everyone needs more support, and that support has to meet them where they are. And that's going to be a critical solution that we have to invest in. Frankly, compared to the cost of medical care and even a primary care physician, which is we're the cheapest of all of them, that is a drop in the bucket. I think the problem is that we don't see that as a solution. We think, medical services are the only answer, rather than thinking about it much more holistically, and particularly from a health equity perspective, and saying, I mean, like I think Kim's point, in countries with universal healthcare, this is still a problem because they still don't trust the doctor. So we have to start to think about this much more holistically. And I agree, like advocacy or navigation is a core part of the ultimate solution.
Fantastic. Well, I look forward to seeing Accolade, Included Health, Transparent, anybody else who thinks they're in the navigation business.
Or not in the navigation business, whatever they want to call it.
No, I'm just kidding. Because those of you who didn't see it, I had Shantanu's boss and also the CEOs of Included Health and Transparent on a session with Jester Master at our conference, in which they were arguing about whether it was navigation or not navigation or whatever you wanted to call it. But advocacy for sure is something that we will need. All right, we have almost come to the end of another great THCB gang discussion, and we're going to quickly go around and see what people are expecting to happen in the next couple of weeks or what you're looking at. So I will start with you, Mike.
Well, I think in the next couple of weeks, we may have some idea whether we're going to have another variant. And if it is another variant, whether it will help along this process or whether it will cause us to have another bump in the road. So I'll be keeping an eye on that.
All right. Janae, what are you looking at the next couple of weeks?
We're looking at more people getting involved who want to help and support, and announcing more of the winners. My kid is banging around upstairs. Do you hear that? And just like more joy in homeschooling and work at the same time and doing everything, just like pure joy.
All right. And where can they find you? Sharpe Index?
Yeah, sharpeindex.org. They can find us.
Fantastic. All right. Shantanu, next couple of weeks, what are you looking at?
Yeah, I think as the numbers come down, I think we're going to get to this really weird spot in 2 weeks where people are going to say, wait, what do I do? Because I don't think that we've reset our expectations or reset what the goal line is. And I think that's going to be the hottest topic in 2 or 3 weeks is like, what's the goal and what are we supposed to do different now that the numbers are back?
Kim.
Well, Mike mentioned that Justice Breyer is stepping down. So obviously I'm waiting for a call from the Biden administration to see if I could be the next Supreme Court. I mean, I've got the old white guy thing down, and once upon a time that would have been enough, but maybe that's not enough anymore.
I was appealing to someone should hire me for it. They told me I needed a law degree. I said, come on. Right. Well, one interesting I'm looking out for the next couple of weeks, because bizarrely, I know the mother of a potential gold medalist next week, is that the Winter Olympics are starting in China. There's a weird conference of stuff going on. First off, they're making all the snow because the place the Chinese have put the main ski areas doesn't have enough snow of its own. It's cold, but there's not enough snow, which is one issue of global warming. Secondly, the Chinese are trying to enforce a complete bubble of the people who are coming into the country to actually do the athletes coming in, because they're trying to stay at COVID zero, which everyone else is kind of giving up on, even the New Zealanders are giving up on. And thirdly, of course, there's a bunch of weird stuff where apparently if you use the app that they have given all the athletes, the Chinese are spying on all of them. There's a bunch of controversy about that. So I think we've got almost everything that we're thinking about in terms of health, society, global warming is about to be unveiled, and we'll find out if there's an Omicron variant or something else weird that goes on in China as the Olympics are going. But do watch Eileen Gu. She's in slopeside and slopeside skiing and halfpipe skiing, and she is a daughter of an old friend of mine representing China rather than the US, even though she's half and half, because I guess she's going to make more money that way. All right. And with that, you've spent another great hour with the THCB gang. Want to thank my guests today. They were Mike Magee from Connecticut, Kim Bellard from the Wilds of Cincinnati, which is a team still mysteriously in the NFL playoffs. Who knows? Anything can happen. Janae Sharpe, these days from North Carolina, but used to be from Utah. And Shantanu Nundy, who I think is from DC. Am I right?
I am indeed.
You're
right.
That has been your THCB gang for January the 27th. We'll be back next week with another different episode of the gang in early February, just in time for the Olympics. And with that, I want to say thanks for watching or listening on the podcast. We'll see you again soon.